So today's session is about living healthy. Basically, it's all about lifestyle advice. So, uh, first of all, I would like to explain to you Q risk. What is Q risk? So, need to do is you have to be very attentive over here so I can start it. Okay. So, what is Q risk? Q risk is that it is a score which is used to find out or that tells us the risk of developing a heart attack or a stroke within the next 10 years. Okay. Ideally, this score should be less than 10. And we calculate this risk by taking into account many factors such as modifiable and non-modifiable risk factors. Okay, so there are certain factors over which we have control. So we call them as modifiable risk factors such as cholesterol levels, medical conditions, high blood pressure, high blood sugar, okay, weight, and we have control over those things. Any sedentary lifestyle and lack of exercise, drinking habits, smoking, so we have control over all of these things. And also we have certain risk factors that are non-modifiable. For example, age. Okay, age is a non-modifiable risk factor, gender is a non-modifiable risk factor, and ethnicity, race, family history, okay, previous history of something such as a cardiovascular event or an event of a CVA. So we do not have control over those things. So that is non-modifiable risk factor. So let's see. We have got over here Q risk score. It is if it is less than 10%, so we say that it is low risk and we have to repeat this test in 5 years' time. And if it is 10 to 20%, then we say that it's moderate risk and we do not have to repeat the Q risk score and we have to start the intervention, whether we are going to place the patient on statins or control blood pressure or any lifestyle changes. We will look into it shortly. And if it is more than 20%, it is high risk. So what is BMI? You have to explain to the patient that it is the relation between body's weight and height. Okay. Ideally, we call it as healthy weight for height. Simple. So normal BMI is 18.5 to 24.9. Overweight is 25 to 29.9. And there are three classes of obesity, class 1, 2, and 3. And that above 30, we categorize the patient as obesity class 1 or being obese class 2 and class 3. Okay. So we have got 30 to 34.9, 35 and 39.9 and above 40. So there are two types of risks, as I already mentioned. So there is a mnemonic or there is an acronym for it. You can remember it by dates. That is diet, alcohol, tobacco, exercise, smoking is the same thing. Okay, stress, high cholesterol levels, being overweight. Okay, and there are non-modifiable risk factors. For example, age, being male, history of cardiovascular diseases, ethnic backgrounds, and family history as well. And there are certain comorbidities such as hypertension, diabetes, kidney problems, heart conditions such as atrial fibrillation, psoriasis. These are autoimmune diseases such as rheumatoid arthritis, SLE. So we do not, these are certain things, comorbidities we have to do, we have to address and we have to deal with them along with the modifiable risk factors. So lifestyle advice, you have to give this advice in almost all the scenarios. So we have started it with, we will be addressing dates in it. Okay, it's diet. So for dietary advice, you have to tell the patient that, okay, you need to take 5 fruits every day and 2 portions of fish every week. And you need to ask them that whether they eat fish or not, because sometimes people are vegetarian and you cannot force somebody to take fruit and take this fish or meat. Okay, so you have to ask for it. And then you have to tell the patient that add adequate vegetables to your diet, and take fruits and vegetables at least 5 portions every day. Okay, reduce your salt, reduce your sugar and fat intake, and change red meat into white meat. And what you can do is, means red meat is all that's beef. Okay, and some people also go for bacon as well. So you have to tell them that you can reduce this red meat to white meat, which is fish and chicken. Okay, and change frying into grilling. Okay, and you can switch between butter and oil. You can change oil, you can replace your oil with butter, and well, you can use oil instead of butter. Okay, so uh, reduce salt to less than 6 grams per day, and avoid eating from outside, because they use a lot of salts and to make food tastier. So they use oils which are sometimes substandards, and junk food. So you need to avoid all that. So you have to tell the patient that avoid eating from outside. Try to cook at home. And if the patient is reluctant, patient says that no, doctor, I am very busy, I cannot cook, and that's why I have to take food from outside. So you can tell the patient, you can give them advice that okay, what you need to do is you can cook on weekends, and you can store it in the fridge, you can refrigerate it or freeze it, and then you can use it for the rest of the week. Okay, that's a solution. And refer to, then at the end you can refer to the dietitian as well, and offer diet sheet to the patients. Okay, and next thing is exercise. Should tell them that okay, you have to go for exercise. Ideally it should be 2.5 to 5 hours per week, and daily you can do at least 30 minutes of exercise, and you can do it in 2 sessions as well, 15 minutes uh, each session for 15 minutes. Okay, 2 sessions of 15 minutes, and take up activities such as jogging, walking, and swimming. And you can also join local exercises groups. Okay, and you need to counsel about smoking. You have to quit smoking, because cutting down on smoking, it is something that won't benefit. Still patient is smoking, cutting down won't be a good option. So because the treatment patient benefits from quitting smoking. So we have a lot of help available for the patients who want to quit smoking. If the patient is reluctant, that doctor, it's difficult for me, I have tried before to quit smoking, but I couldn't quit. So what you need to do is you have to tell them that we have a lot of help available, and what we can do for you is we can refer you to smoking cessation clinic. If you want to quit, you need to motivate them. You need to tell them that okay, we have help available for you, we have alternative forms available. Instead of smoking, you can go for these alternate methods, as long as because it's not a one day task that you just make your mind and I'm going to quit smoking. And it's we understand that it is difficult, so you can counsel them in this way. And then alcohol, that you should be knowing that normal limit of alcohol is less than 14 units per week, with at least 2 alcohol-free days. And you should always have room to improve alcohol, because if a person is taking alcohol, for example, 5 units per week, so you can still counsel them. You can still tell them that okay, you are drinking 5 glasses, that is within the normal range, or less than 14 units per week. So, however, we would like you to cut down on your drinking. Would it be possible for you to do so? Okay, because it is ultimately going to benefit you. So you need to, even if they drink 1 glass of wine, ask them to reduce to half glass. And then we are going to talk about blood pressure control. So for the patients aged between 40 and 80 years, what we need to do is we have to take blood pressure readings. And if the reading is more than 140, so we go for 3 readings. We repeat the blood pressure, take 3 readings at different intervals at different occasions. Okay. And if still high, then we go for ambulatory blood pressure monitoring, and we send the patient home with the monitor attached. And when home blood pressure, that is ambulatory blood pressure, also comes same, it's same, that is higher. So then we will decide whether patient has we will be labeling patient as hypertensive, or whether the patient needs lifestyle modification, or whether they need medications. Okay, so if the patient is under 40, you need to send them to the specialist, because young age, there could be a number of reasons for high blood pressure, including we can have polycystic kidney disease, adult polycystic kidney disease. Okay, pheochromocytoma can be there. So you need to rule out certain causes. Therefore, you need to send younger patients to the specialist. And there are certain terms that we will be using in the scenario. That's why I'm explaining all those things, that everything should be clear in your mind, so that you should have at least background knowledge, that whenever you are dealing with those things, or in any scenario, whenever when your time's up. So what you can do is, you think that it's medicine scenario, and you are still left with some time. So what you can do is, you can go for lifestyle advice as well. You can tell them that, okay, as you had heart attack, or you had a stroke, so I would like to discuss some interventions or some advice. I would like to give you some advice regarding your lifestyle. So what do you think about it? And then you can discuss it over there if you have it in your mind. Okay, so this borderline blood pressure is if the home blood pressure reading is less than 155 millimeters of mercury, we call it as borderline blood pressure. And if the clinical blood pressure is less than 160, we call it as borderline blood pressure. This difference of 5, it has been kept because sometimes people do have white collar hypertension, meaning that when they come to hospitals, or when they come in contact with any person who's working in the hospital, so hospital, maybe a hospital nurse, hospital staff, doctors. So there are some people whose blood pressure tend to rise. So that's why its cutoff value is less than 160 in GP clinic and less than 155 in it is 140 to 155, means still less than 155, because if somebody is having blood pressure more than 140, then we go for labeling, or we tell them that, okay, you are having blood pressure on higher side. So how to define, how would you explain it to the patient that what is borderline blood pressure? You have to tell that it means that blood pressure is high, but initially for the first few months, we can try and reduce the blood pressure by making some changes in lifestyle, such as reducing weight, cutting down salt intake, exercise. Okay, and you can tell them all about other lifestyle changes as well, cutting down on drinking, making changes in their diet. Okay, so this is the way you explain it to the patient. Okay, so there is an important thing, let me explain it to you, that when we go for lifestyle changes and when we start medications, if the patient has borderline blood pressure and he does not have any other risk factor, so we go for lifestyle changes. And if a patient is having borderline blood pressure plus risk factors, for example, positive family history for stroke, high blood pressure, diabetes mellitus, okay, and if they are heavy smokers, then we need to treat, we need to give medications. Okay, so when we have done, we have started lifestyle modifications, and we are following up the patient, and we see that there has been no significant improvement in patient's blood pressure, then what we do is we go for ambulatory blood pressure. We check it, that if it's ambulatory blood pressure is more than 155 or clinical blood pressure more than 166, we start medications. And usually the choice of medication is that we start with a single medication. If the patient's age is less than 55 and they are non-Afro-Caribbean origin, okay, they are Asian, they are white, then we go for ACE inhibitors, that is angiotensin converting enzyme inhibitors. Okay, we start with it, patients less than 55 years old and non-Afro-Caribbean origin. And if patient can't tolerate ACE inhibitors, then we go for angiotensin receptor blockers. They are more or less the same things, but mechanism of action is that one acts by blocking this angiotensin converting enzyme in lungs, and other blocks the receptors. Okay. So sometimes people do get cough with ACE inhibitors. So you need to change, you need to just switch the class. Okay. So if the patient is above 55 or regardless of the age, if they are Afro-Caribbean, okay, normally if the patient is above 55 and they are Afro-Caribbean, and then you do not look for age. If the patient is Afro-Caribbean, you do not go for age. You just start with calcium channel blocker. That is the medication of choice. Okay. And if patient is diabetic, then we have ACE inhibitors as medication of choice because they are renoprotective. And patients on ACE inhibitor and ACE inhibitor drugs wants to get pregnant, then what advice you need to give them? You need to tell them that while you are on this medication, you need to be on contraceptives, remain on the same medication. You need not to change the medication. And once your blood pressure is controlled, okay, you need not to get pregnant until we will be referring you to your obs and gynae, and they will be making the decision whether your blood pressure is controlled or whether they can give you some alternate medication, because they will be giving you the very first advice is that if you can get pregnant with this blood pressure. Okay, that's why it is necessary that we do ask the patient to come for dating scan and booking blood pressure as well. Okay, so then if they can say that, okay, with this blood pressure you cannot get pregnant, then they can change the medication, they can modify the medication. They will be telling you that, okay, which medication you need to and when should you get pregnant. And then we offer different medication because we cannot start with these conventional medications, that is ACE inhibitors or calcium channel blockers. We have to go for most of the time we go for alpha blockers, just like Aldomet. In our setup, we usually give Aldomet. Sometimes we do give calcium channel blockers as well. So we also give beta blocker medication such as labetalol. All right, so we have to change the class. So let's begin with our first scenario, that there's a patient with high BMI and statins. Okay, the patient has got high BMI and we need to start patient on statins. So you are FY2 in GP surgery. Mrs. Lena Brown has come to the practice for her well women follow-up. Blood tests were taken and examinations were done. Full blood count, LFTs, TFTs, and urea and electrolytes are normal. BMI is 28. So the patient is falling under the category of overweight. Okay. And cholesterol on 2 occasions was 6.2. That is high. And Q risk score is 14%. It is also intermediate risk. She has been planned to be started on the statins. That's why you have to explain the examination findings and discuss management plan with the patient. So let's see how to approach the scenario. But before that, patient might be having some questions that, okay, doctor, you are going to start me on this medication. First of all, they will be asking you about their tests. Okay, doctor, tell us what is in the test. What does the result suggest? Okay. And if you are going to start the medication, patient might ask the side effects, side effects, and they would be seeking advice for reducing their BMI. They might not be knowing about BMI, so you have to tell them. And they might ask you that, okay, doctor, when you mention this BMI, so they might say that, doctor, okay, do you think I'm obese? So these are some concerns that patient might have. So you have to explain all those things to the patient. So you will be starting with a normal approach, same approach that start with the grips after introduction, with the smiling face, and be confident, loud, and everything like that. And then you need to explain the results. You need to explain the results to the patient and ask them, okay, I need to ask you a few questions. I understand that you had been here and you had some blood tests done. So could you please tell me what made you come to the hospital? Why did you do these blood tests? Has anybody explained the results to you? Okay. She would say, no, doctor, you are the first one I'm seeing. Then you can say, okay, I'll be explaining the results to you shortly. I have got the results with me, but before that, can I ask you a few questions? You can take the history basically, or you can explain the results. And then after that, you can explain the result that, okay, I've got your results with me. I'm going to tell you that, okay, you had this blood test done, full blood count, liver test to check your liver functions, your thyroid functions, and also to check chemicals in your body. And I'm glad to tell you that everything, all those tests are normal, apart from some high cholesterol. Okay, and cholesterol in your blood is high. That is, they are above the desired levels in the body, and also your weight or height is also high, on higher side, and we call something as what we call as BMI, that is body mass index. So we calculate it by dividing your weight over your height. So I have got this with me. It is 28. So you lie in the category of, or you fall in the category of overweight. Okay. Then you have to explain it this way. And then you need to tell them about Q score as well. You can tell them. And then you can ask that, okay, I need to ask you a few questions to see that what is causing this high levels of cholesterol in your body, and why is your weight on higher side, or why do you your weight lies in overweight category. Okay, then you can go for systemic review, ask everything, that is, go for this PMMA, past medical history, medications, allergy, hospitalization, family history is very important. Okay, then you need to ask for any risk factors such as diabetes, hypertension, alcohol, cholesterol, any history of heart diseases or heart problems such as atrial fibrillation. Okay, and then go for DESA, that is diet, exercise, smoking, stress, alcohol, any recreational drugs, and you can ask all those things. Okay, and then you need to ask the patient of that what is there anything else we haven't discussed, or would you like me to tell that we have missed so far. Then you need to ask that, okay, what could be the reason, what do you think, what causes this abnormality in your blood cholesterol levels, or what is the reason. They might tell you that, okay, it's familial because my mother was obese, my father was, my sisters, and then so I'm still this runs in our family. Okay, so you need to find out, and then you have to explain all those things, like you have to explain BMI, Q risk, and then summarize everything and explain high levels of the cholesterol as you have already explained. And then you will be telling that, okay, as I've found out that, having listened to you and keeping together your blood test results, we think that you need to take some medication. We are going to start you on medication that would be lowering your cholesterol levels, and these medications are called statins. Basically, we give these medications to lower the cholesterol levels in the blood. So you have to take, you will be telling that how do you take this medication. You have to take this medication every day at night before going to bed. You have to take it once every day. All right, and then they might ask about some side effects. You have to explain the side effects. Whether they ask or not, you have to explain side effects, that okay, you can have some muscle cramps, you can have headache with it, and drowsiness, and sometimes stomach upset or tummy upset can occur with this medication. Okay, and then you have explained the Q risk score, that okay, this is a score we used to calculate to see that, okay, what is the risk of you getting or having a stroke or any event, cardiovascular event, stroke, or any cardiovascular event in next 10 years. So we have calculated, and in your case, it has come to be 14%. Ideally, it should be less than 10%, but it's 14%, which is higher, and we label it as intermediate score. So I would like to advise you, or I would like to share some precious piece of advice with you to see that how we can cut down, or how can we decrease this risk of you developing heart attack or stroke in next 10 years. And then you will start with your dietary modification. Tell them about lifestyle advice. Basically, you will be doing lifestyle advice. Start with diet, then alcohol, then tobacco, smoking, then exercise. Okay, ask them to go for exercise, and any stress, anything like that. They need to sort out things. And you have to give them all lifestyle that we advise that we have discussed above. Okay, the next scenario is high BMI with low Q risk score. So here the patient has got a URFY2 in GP, 60 years old, has come for follow-up. 1 week ago, he had a blood test done, blood test all normal, cholesterol normal, liver function normal, ECG normal, BMI is high, 28.5, which is overweight, and BP is 150 over 105, and Q risk is 9.1%. So you have to talk to the patient. You have to explain the findings and discuss the management with the patient. So let's see how to approach, because it's a follow-up scenario. You will be starting with, okay, nice to meet you again. I'm Dr. Emma, one of the doctors working in this department. I understand you were here a week ago and you had some blood tests done. So could you please tell me, why did you do those blood tests? If the patient says that, doctor, I'm concerned about my health, and I saw a poster on TV, or I saw an ad or a poster, so I thought that let's get myself checked, so to see if there is anything wrong with me. And then you need to appreciate the patient as well. Okay, that I appreciate that you're concerned about your health, and it's very good thing that you do care for yourself. Okay, and patient might ask you some question that, doctor, what risk I do have, and do I need to take any medication? Then you will be once you have started it, then what you need to do is you will be checking. You will be, because this BP has been given over here, we are not sure that whether this is clinical reading or ambulatory blood pressure. Okay, so we have to make it sure that whether it's ambulatory or clinical blood pressure. We will be double checking. We will be telling them that, okay, we have taken your reading. I have reading with me, but could you please tell me where this reading was taken, whether it was taken at home or was it taken in the clinical, was it a clinical reading? Okay, and then you have to tell them that, okay, if the blood pressure is, like I have already told you, that if the blood pressure is more than 155, then we go for 24 hours ambulatory blood pressure monitoring. And then if more than 155, we go for medications. And if it is less than 155, it is now less than 155. If it is ambulatory, then what we can do is we can label it as borderline, and we can go for some lifestyle changes. So it comes under the category of borderline blood pressure if it is this is ambulatory blood pressure. Okay, if it's not a clinical reading, because clinical reading needs to be higher. It should be less than 160. So we will consider this as a borderline BP. This is the blood pressure where we consider starting medications, or we most of the times we go for lifestyle changes. And by bringing some change in your lifestyle, we can control your blood pressure. So would you like me to explain all those? Would you like me to explain those things to you? So you will be telling that, okay, you need to explain that we need to explain about Q risk as well. We have to calculate, we have to ask them that, okay, we can calculate your Q risk as well. Explain about BMI, that it is BMI, your weight is high. And then you will be simply doing that systemic review, go for past medical medications, allergies, and PMMA, Holy Family, DESA, RS, totally. You have to ask all those things. And after that, what we do for management, because the basic approach is the same. You have to, it's all about talking and talking to the patient. Okay, you should have these strong concepts in your mind, so that you should be able to convince the patient. You should be able to talk to the patient, whatever they ask you, because these are certain things. The patient might ask you some questions, and then you can answer those questions easily if you are having blood pressure. That, Okay, patient is saying, doctor, what medication are you going to start me? If the patient is young patient, since this patient is more than 55, then we know that it's understood that we are going to start them on calcium channel blockers. If it is the patient was less than 50 years old, then we would have started on ACE inhibitors. Okay, then what you need to do is you have to explain the borderline blood pressure, explain them, and then give them lifestyle advice, starting with dates, diet, exercise, alcohol, tobacco, smoking, stress, everything. You have to give them this advice. Okay. And then what you need to do is in this scenario is what you will be doing is you have to once we have made some intervention means that lifestyle modifications, so we need to follow up. Patient is having blood pressure, that is borderline blood pressure, plus we made some lifestyle changes, then we need to review the patient within 2 months time. Okay, we have to follow up in this patient, we have to have follow up with this patient in 2 months time. Okay, so let's move on to the next scenario, because basic approach is the same. That's why I discussed those things in the beginning in detail. So patient is having hypertension and the patient is worried about stroke. You are the FY2 doctor in general practice. Your next patient is at 67 years old, Mr. Zimmerman, who has come to your practice to see a doctor. The nurse has checked the patient's blood pressure and it is 160/90. So it's a clinical reading. Please assess and manage this patient. You do not have to perform examinations. Okay, so what are the questions? I heard the word borderline. What does that mean? So you have to explain the borderline. How can you help me with diet, doctor? What is the risk that I'll be having a stroke? What can I do to prevent stroke? So this scenario is that the patient is concerned about stroke because his father had stroke and he died at a young age. Means young age, I would like to say that as compared to other people in UK. So he died at a very early age, around 55 or 60. So that's why he's concerned, and his brother also had stroke. So he is concerned that he has a family history because he had watched on TV, or he might be hearing it from some other friend or any poster. He might have read it in any poster. So he has come to you and he's asking for it. So you would be starting would be like this. Okay, how can I help you? You should start with the grapes and then ask that, okay, how can I help you? So then is there any particular reason you're worried about stroke? Then they would tell you, the patient would tell you that, okay, doctor, my father had stroke, my brother had stroke, so now I'm concerned about it. So you need to feel sorry. You have to apologize that I'm really sorry to hear about your father and brother. So how is your brother doing now? And you can ask, these are the things that things that count towards your IPS. And then after that, you have to tell, okay, you have to ask that, okay, I can definitely help you with that. But before that, I need to ask you a few questions to be in a better position to answer everything you need. So is that okay with you? And then the patient would say, yes, doctor, it's fine. Then you start with the history that you will be starting with this systemic review, ask for PMMA, Holy Family, DESA, RS, TOLI, and then particularly you need to ask for his family history, because it is a family, he has got family history. You have to go for other comorbidities such as hypertension. He is having hypertension. So hypertension, diabetes, any liver problems, any kidney problems, and any previous history of TIA. Okay, so any heart attacks. Then ask ICE, ICE. So that is there anything else we haven't discussed so far, or you would like to tell me anything in particular you're concerned about, anything you think could be the cause for your high blood pressure? And then you have to tell them, you have to discuss the risk. Okay, that he is asking you that what is the risk that I'll have stroke. So then you have to tell them that, okay, there are certain types of risk. Some are modifiable and other non-modifiable risk. Modifiable risk are, you have to explain the way that, okay, these are the risks that which we do not have much control over them. We cannot change them. And modifiable risk factors are those we have control over them, and we, by making some lifestyle changes, we can reduce the risk and we have control over them. So you have to explain this to the patient. And when you have taken your history, you have completed the history, and then when you are going to explain it back to the patient, you have to tell them that, okay, after talking to you, I feel, unfortunately, you have got some risks because you have a family member with stroke, and your father has died of stroke, and you also lead a stressful life. For example, the patient is a businessman and he is really busy. He's always on business trips. He's not able to maintain healthy diet, and he's smoking and he's drinking as well, and smoking for the last 20 years. So what you need to do is you have to tell them that you do have got some risk, and we have to calculate your Q risk. We have to do Q risk, which is something we use to calculate to find out the risk of developing stroke or heart problem or heart attack in the next 10 years. So what you need to do, examiner, if you mention Q risk, examiner might give you Q risk, but maybe they might not give you Q risk as well. Okay, so you have to talk about hypertension and he is worried about, and then you have to explain the borderline blood pressure, as I already explained it twice or thrice. So I won't be going through it. That, okay, we go for certain lifestyle changes, and then we will be following up. If the lifestyle changes do not help you, then we can change. We can go for medications as well. Okay, and you need to explain because patient is concerned about stroke, so you need to tell them sign and symptoms of stroke. So there is a mnemonic, or there's an acronym for stroke, warning signs of stroke. So these are FAST. Okay, FAST. So FAST is an acronym. F stands for facial asymmetry. Okay, if the patient notices any change or any dropping of any side or any part of the face, the patient should be aware of it. That is, it is a sign of stroke. And if any weakness in any arm or any part of the body, half part of the body or any part of the body, then the patient should be concerned that it is a sign, again, another sign of stroke. And then S, difficulty in speech or slurring of the speech, it is also a part or a sign of stroke. And then T is for time to call an ambulance, as these are the signs of stroke. So patient needs to call the ambulance immediately because he is having a stroke. Okay, so you have to tell them. And then we have got this patient with high blood pressure. This is a clinical reading. As I told you that this is a clinical reading. Then we go for ambulatory blood pressure monitoring. And in this case, what we will be going to do is we will be asking the patient that, okay, what we are going to do is you can make lifestyle changes and also what we will be doing is we are going to monitor your blood pressure while you are walking around or while you're doing your normal daily life activities. So that is ambulatory blood pressure for 1 week, and then you can follow up in 1 week's time to discuss or to see how things are going with them, and tell them that, okay, if you feel any sign of the stroke, then what you need to do is you have to call the ambulance and come straight to the hospital. All right. So sorry, I feel sleepy. Today has been really hectic. So the next scenario is a patient worried about vascular dementia. So high BMI, same thing, just a few explanations of the condition, that what is vascular dementia. Okay, here FY2 in GP surgery, patient is a 45 years old lady who has presented with some concerns. Other information, She has psoriasis and she uses ointment, that is steroid ointment, most likely. And BMI is 32. So she is obese, category 1, class 1. Talk to the patient and address her concerns. And then what is vascular dementia? She's asking for it, and how can I reduce the risk? So how to approach the station? You will be approaching with grips, that how may I help you, and any particular reason that you are worried about. She would say, doctor, I'm worried about vascular dementia. You would ask that, okay, what makes you worry about vascular dementia? Any particular reason? Then she would say, doctor, my mom had vascular dementia and she died, and my sister has also got vascular dementia. That's why I'm concerned. So there is a strong or positive family history. Then you have to signpost that, okay, I'd like to ask a few questions so that I'm in a better position to tell you whether you have the risks of developing vascular dementia or not. And then ask about modifiable risk factors and non-modifiable risk factors, and basically go for PMMA, Holy Family, DESA, RS, totally, and ask about this. ICE, AICEIS, and then what you need to do is you do not have to go for examination in this scenario. Then explain, okay, explain that, okay, BMI, explain BMI, that, okay, we have measured your BMI, which is 32. And you have to explain that what is BMI, that is the ratio, or it is the relationship of your weight to your height. So normally the normal BMI is between 18.5 and 24.9. You have to explain it. And then we have measured your BMI, which is 32, and it is higher. So you fall under the category of obesity. Okay, you don't need to tell that class 1, 2, or 3. You just need to tell that, okay, you are falling in the category of, we categorize body weights on the basis of BMI. So your body weight falls in the category of obesity. Okay, and then you have to tell that you mentioned about vascular dementia. Let me explain it to you, that it is caused by reduced blood supply to the brain cells, that causes destruction of the brain cells. Okay, or reduced blood supply causing damage to the brain cells. And it can be caused by either a single big stroke, okay, or small or multiple mini strokes. Okay, multiple mini strokes. The reason could be single big stroke or multiple mini strokes. So what causes a stroke? She might not be knowing about the stroke. So you can tell them that, okay, strokes are basically or usually caused by narrowing of the blood vessels. And from the information, what I gather is that you do have some risk of developing vascular dementia, because you have got a family member who has vascular dementia, and your mother also had the vascular dementia, and you have certain medical conditions such as psoriasis. She has got psoriasis and she has been using ointment. So she will be telling you, the doctor, I'm using steroid ointment for this much years. So you have to tell that you have got psoriasis, and this is another risk factor, that you are using steroid for it. So you can have some risk factors now of developing vascular dementia. So your BMI, another thing is BMI is 32. So your BMI is also high. So all of these factors contribute, or they increase your risk of developing vascular dementia. So there are, we are here to help you. There are certain things that we can do for you, and certain things that need to be done by you. What would you like to know first? Okay, she would say, doctor, tell me what you can do for me. Or she might say, okay, okay, doctor, tell me what I can do for myself. And you will be telling that what we can do for you is we will be ordering some blood tests to see that, okay, you do not have any medical conditions that are causing you to have high BMI, or that might contribute to your risk of developing vascular dementia. Okay, we will be ordering routine bloods, your full blood count, urea electrolytes, liver function test, your kidney function test, okay, your thyroid functions test, and all those things. And if we find your blood pressure, your test for um, blood sugar, so if we find any abnormality in those tests, then we can address those abnormalities by starting medications. Okay. And what you need to do is you have to tell them about lifestyle modification, give them lifestyle advice starting with dates, tell them about diet, and alcohol consumption, reduce alcohol, tell them about tobacco, smoking, go for exercise, cutting down on smoking, and stress, coping up with stress, okay, and all those things. You have to give them lifestyle advice. And we have got another scenario. That's all about the scenario. So, hypertension with high Q risk score, high Q score. So it's the same scenario. We have already discussed scenarios. It's the same. So you are FY2 in GP surgery. Richard Branson, a 50 years old man, has come for. He came last week and had some tests done. He was placed on 24 hours blood pressure monitoring, and average BP is 65/95. So it is high blood pressure. Ambulatory blood pressure is high. So it means blood pressure is high and he is hypertensive. Q risk score is, or Q score or Q risk is 16% and BMI is 28. Talk to the patient, address the concern, address further, and discuss further management with him. So what we need to do is we need to go with the same approach that, okay, I understand this is your follow-up appointment. You had some blood tests done. Can you please tell me, we place you on ambulatory blood pressure monitoring, and how are you doing with that? So I understand that your blood pressure has come higher. So we are going to start you on some medications, and your BMI is also high, your risk is high. So what needs to be done? We will be starting with, because it's ambulatory blood pressure, it is not borderline, it is more than borderline. So we are going to make interventions over here. Then you have to explain all those things, everything in the same manner as we have done in already in the above scenarios. And here what we need to do is we have to intervene with medications. So what we will be starting, because patient is less than 55 and they are not Afro-Caribbean as well. Therefore, we are going to, the drug of choice will be ACE inhibitors. So you have to tell them that, okay, we are going to start you in this medication. He might ask you some side effect. What are the side effects, doctor? You have to tell them that, okay, it might cause you some cough. Okay. So we can, if it causes cough and that becomes troublesome, we can switch you, or we can change this medication to another medication called ARBs. Okay. And also tell them that it can also have effects on the kidneys sometime. So we need to check your kidney function test. Basically, it's a recommendation that whenever you are going to start the patient on ACE inhibitors, you have to go for kidney function test, check the RFTs, and if the RFTs are fine, then you can start. And if the patient, you have to do RFTs after 2 weeks as well. Once you have started on ACE inhibitors, do do RFTs after 2 weeks of starting ACE inhibitors, because it can damage the kidneys, or it can cause rebound hypertension in patients. You have started ACE inhibitors and blood pressure goes on rising, and RFTs are going to derange. So it means that patient is not responding to ACE inhibitors. And then you have to tell them that we will be monitoring your kidney function test, and if there is any derangement or any problem, we can change the medication. And then explain about the Q risk, that, okay, we also calculated your Q risk score, which is intermediate, and what you need to do next is you have to tell that it is the risk score which we do to check a person's risk of developing stroke or heart attack in the next 10 years, and it's a numerical value given in percentages. So you have got a moderate risk. So I would like to ask you, you have to take the history again, take history and address their concerns. Okay. And then give them lifestyle modification, or advise them over lifestyle changes as well. Okay, so that's all about Q risk, hypertension, BMI, and blood pressure monitoring and management. If you have any questions so far, you people are more than welcome to ask. So we are going to start with TIA scenarios. Okay, so let's begin with it. TIA. We have got it. There are all those scenarios are more or less the same. Patient might be just the name of the patient may be changed, or the activity they are doing at the time they experience those symptoms, they might be changed. Rest scenario approach is the same. Okay, so that's why I have written scenario A, B, and C, and then TIA and a taxi driver. We will be shortly seeing that, okay, what is the significance of TIA in a taxi driver, what has to do, what TIA has to do with this taxi driver. So I have written over here that there are two scenarios, A and B. You are FY2 in A&E. Linda Jones, 69 years, has been brought to the hospital by her husband due to the weakness on one side of the body, slurred speech, dropping of angle of the mouth, and difficulty in swallowing. Symptoms lasted for 15 minutes, and it happened 3 hours ago. And general and neurological examination have been done, and there were no findings. BP was measured and recorded as 150/95. Routine blood tests has been done and still awaited results, or still awaiting results. CT scan of the head has been done and it is normal. She has been referred to the TIA clinic tomorrow. So she will be going tomorrow. Take history from the husband. Assume consent has been taken from the patient to talk to her husband. Patient is completely fine now, but she is too upset to talk and she has asked to talk to her husband. All right. This is scenario 1. Okay, scenario A is that the patient, it is the patient info that I have shared here, so that you should know that, okay, they can present differently with this type of scenarios. So you were watching TV at the time when your wife developed, it's the husband's note that when your wife developed symptoms of weakness in her arm, difficulty in speaking, and dropping of the corner of her mouth. Symptoms lasted for about an hour. You have seen your wife now, she's completely fine, and you are delighted with this, and he wants to take his wife home. So there are certain questions from his side. Will it happen again? Is there anything she can do to prevent this from happening again? What caused it, doctor? What are you going to do for her? And what is TIA? Okay. And scenario B is a 57 years old lady. Husband was in the kitchen with his wife when she developed difficulties in speaking and moving her right arm after for 15 minutes, and he took her to the hospital. And questions are, can I take her home? What caused the problem? And will it happen again? What do we need to do to prevent it from happening again? So these are some questions on patient side. So let's see how to approach this scenario. Approach will be the same. You will be starting with same approach. Start with grips and greet the patient, build rapport, introduce yourself, state the purpose or paraphrase, and then you should be having a smiling face. Okay, and you should be loud, confident, and after that you have to check the relationship, introduce yourself, and after that you check the relationship. You should be knowing the name of the patient. Okay, may I confirm your details, please? Could you please tell me how you are related to Miss Linda Jones? So they will tell you that I'm her husband. Then check for their understanding that, okay, what have you been told so far? I understand that your wife has been admitted, or you brought your wife to the hospital. So I would like to ask you that, what do you know about her condition, or what have you been told about her condition? Basically, you need to take history, and then you start taking history and ask for uh, incident history, that what happened, how did it happen. You have to go for incident history and ask for symptoms of TIA, that, okay, what symptoms did she have. You have to rule out other things, that, okay, did she have weakness in any part, which part of the body was it, did she experience any loss of sensation, any loss of coordination, any syncope, did she fell to the ground, loss of vision, any problem with the speech, any difficulty in talking. Okay, then you have to go for the risk factors. Ask for risk factors. Basically, you have to take the history. Risk factors as high blood pressure, high blood sugar, previous history of stroke or TIA, any family history of TIA, any heart problem, any history of atrial fibrillation in the past, and then go for social history, such as smoking, diet, exercise, alcohol, passive smoking, anything like that, any stress. Okay, and then you need to explain the examination findings, that okay, we have, once you are done with it, you need to ask for eyes as well, and then you can go for examination finding, that okay, examination has been done, examination was done, and we have found that everything is normal. Okay, apart from high blood pressure or what. So then uh, you have to tell that she has had TIA, which is we call as transient ischemic attack or a mini stroke. Okay, and you have to explain that a TIA or a stroke usually, or a mini stroke usually develop if there is blockage of blood supply to the brain, and this is usually due to the blood vessels that become narrow, and sometimes there is reduced blood supply to the brain. And transient means it is short lived, that is symptoms last for less than 24 hours, and if last more than 24 hours, then we call it as a stroke. Okay, and there is permanent damage in case of stroke, but in TIA symptoms resolve without causing any permanent damage. Okay, they are short lived, that's why it is called TIA, transient ischemic. Ischemia means reduced blood supply to the brain because of the narrowing of the blood vessels, and stroke is that the resultant the thing, or the results of this narrowing of the blood supply that leads to this deficit or this problem that's resulting, is slurring of the speech and all those things. So this is TIA, attack, transient ischemic attack, and stroke. You have to tell the differences as well, that okay, they might not consider it as, they might misunderstand it as that it might be a stroke. So you have to tell them that it is a TIA. Okay, and then you have to tell them that he might ask you that, okay, doctor, can you tell me that why this happened? What is the reason why this happened to my wife? If you had taken adequate history, then you would be able to answer them that, okay, I've asked you everything, and I understand that she has got some risk factors for it. That could be a reason. And also, if somebody gets older, so in this age, she's 67, I guess, and at this age, the blood vessels become narrowed, and a person is more likely to suffer from mini stroke or stroke. So he asked that, okay, doctor, will she develop it again, or does she have any risk of developing again, or a big stroke, or whatever, will it happen again? Then you have to tell that, okay, unfortunately, if someone has suffered a mini stroke, they are at high risk of developing a stroke. Okay, so we need to refer her to risk assessment clinic, that is TIA clinic, or stroke specialist, to the TIA clinic to be assessed by the stroke specialist. All right, so you have to tell that, okay, she will be seen, or she will be reviewed tomorrow. Okay, here is something I would like to discuss with you, that okay, if the patient has got low risk, refer the patient to outpatient TIA clinic. Okay, you refer them as an OPD case, and tell them that they should stop driving for 1 month after a TIA. It is a recommendation of NHS and DVLA, Driving and Vehicle Licensing Authority, that they should stop driving for 1 month. And the other things is that what you can do now is you can order for some investigation, because you have taken the history. You can go for some examinations are normal, then you can say that, okay, we will be referring her to the stroke specialist, who will be reviewing her tomorrow in the TIA clinic. So meanwhile, what we can do is we can go for some investigations, including blood tests, because they've already been sent. So we are waiting the results, and other tests including blood cholesterol, blood sugar level, CT scan has already been done. You have already explained it to them. But if not done, in case if not done, you can go for this as well. Okay, CT scan, ECG. All right, that is heart tracing. And then you have to manage this patient till this patient has been reviewed by a stroke specialist. So what you will be doing is you will be giving them aspirin 300 milligrams. Aspirin 300 milligrams. Okay, that is 4 tablets of aspirin. And then reassess within 24 hours or assessment by TIA clinic. You have to refer them. And you have to inform them of the signs of the stroke. And what are the signs of the stroke? Tell them about FAST. Okay, that is FAST acronym: facial asymmetry, any weakness in any part of the body, and any slurring or difficulty or speech difficulty, and they need to call an ambulance. T is for time to call an ambulance if they have any of those symptoms, and advise them not to drive for 1 month. Okay, and you have to give advice on lifestyle as well. In this scenario, you have to give lifestyle advice. That is, you can start with dates, that is diet, alcohol, tobacco, exercise, smoking, stress, everything like that. Okay, all right. Another important information I would like to share with you is that generally if a patient had a stroke within 1 week, okay, 1 week's time, they had a stroke in 1 week's time, he or she needs to be seen in a TIA clinic within 24 hours. Okay, stroke within a week's time, they need to be seen within 24 hours in TIA clinic by the stroke specialist. If the patient had a TIA more than 1 week ago, then they can be seen within a week's time. Okay, so within a week's time. If more than a week's time, TIA has happened, because already they have delayed, they came to you after a week, so you can have some time, you can refer them within a week's time. But if they have developed in this week, they presented to you before the week ended, so you will have to send them. They must be seen within 24 hours. Okay, and then if they want to know about that what they are going to do in TIA clinic or what the specialist would do, then you have to tell them that, okay, we are going to send you the specialist. They will perform some further investigations such as Doppler scan, which is a colored scan of the blood vessels in the neck to check any blockage of the blood vessels that might have led to this condition. And they might also consider starting you on some medications, including lipid lowering medications, cholesterol, those are the medications for cholesterol. Okay, and they might consider starting you on medication for your blood pressure. All right, so you have to discuss all those things with the patient. You have to tell them about it. And in both cases, both the scenarios approach will be the same. And you have to the question they ask that, doctor, can I take her home? Then you should tell them, yes, you can take them home, but what you need to do is you have to come tomorrow, you have to visit, or you have to take her tomorrow to TIA clinic. What caused the problems? That is that you have, if you have asked, you have taken adequate history, you should be able to answer that, okay, it is because of the age or any risk factors or any previous history or high blood pressure or any clot or anything like that. Will it happen again? Yes, unfortunately, if somebody has suffered TIA, they have risk of having this again, and they might develop stroke even. Okay, what do we need to do to prevent it from happening again? Then you have to tell them that, okay, we have to go for lifestyle advice. Tell them about lifestyle advice and address any cause which is there, underlying cause, address any underlying cause. Okay, see, okay, another scenario. You are FY2 in GP, 68 years old, made an appointment to see you, talk to the patient and address his concerns. So Sometimes the scenario might come like this, that you might not be having any information. So patient has come to you, and you have to take the history, and then you will be starting, okay, how may I help you? In this case, you won't be saying that, oh, I understand that you visited a few days ago, a few weeks ago, and you had this problem. No, basically it's a follow-up scenario, but it has not been given there that it's a follow-up scenario. So you will be asking that, okay, I'm here to talk to you. Do you have any concerns, anything in particular you would like to ask, or how may I help you? A nicer way of saying that, okay, how may I help you today? Could you please go on and tell me how can I help you today? And then basically this is a patient. Let me brief you about this patient. Short history about the patient, that this patient was brushing teeth yesterday when he noticed that his mouth deviated to one side, and his water was drooling from one side, and he had these symptoms for 20 minutes, and after that 20 minutes his wife noticed, and she took him to the hospital, and now he is here, and he is asking some question. He has some concerns, and his questions are there. So what you are going to do is, you will be starting with normal, that approach is grips. After grips, ask that, how may I help you today? You have to take the history, that okay, what kind of symptoms did you have, and ask about symptoms of the stroke or TIA, which I have already discussed. That ask about facial asymmetry, arm weakness, speech difficulty, any problem with the balance, any blackouts, any difficulty with vision, any problem with vision, dizziness, how long did the symptoms last, and any symptoms now, and how are you feeling at the moment. And then go for systemic review with PMMA, Holy Family, DESA, RS Toli. Okay. And then ask about AICEIs. And then they will be telling you, doctor, this could be. And when you are going for systemic review, you have to ask about this social history or occupational history. So the patient might tell you, the doctor, I'm a driver. So driver, it is very important, very, very important occupational history over here in TIA, that he's a driver. So what you need to do is, you need to tell them to stop driving for 1 month. And it is again a problem if you are going to tell them to stop driving for 1 month. So he will be having concern, the doctor, I am a driver, so I depend on driving for earning. So how can I stop my job, and how will I survive if I quit driving for 1 month? And then you have to address it. So what you need to do is, you will be doing some examinations in it. Go for neurological examination to see if there is any neurological deficit at the moment. Check for heart, examine the heart and chest, and check observations, and explain the diagnosis to the patient as TIA, that is transient ischemic attack, that it is temporary or for short time, ischemia due to narrowing of the blood vessels, leading to decreased blood supply to the brain and causing those symptoms. So that is mini stroke, you have to explain. And what you need to do is, the patient has presented immediately to you, so you will be referring this patient immediately to the hospital. Advise the patient to go to the hospital immediately. And then he will be asking there, what will happen over there? You have to tell them that you will be seen by the specialist, that is stroke specialist. They might do some special tests, including the CT scan, your heart pressing, and all those things, and tell them not to drive for 1 month. And if TIA is confirmed, okay, like they have to stop driving because they need to go to the hospital. If it is confirmed that it is TIA, then they have to stop driving for 1 month. Okay. And safety net for fast, the symptoms on signs of the stroke, basically. And then they will be asking you, the doctor, is it a big deal? So you have to tell that, unfortunately, it is a big deal. It is a potentially serious condition. There is a possibility to develop stroke. Okay. Yes, I am going to explain it shortly. Just a second. I'm going to explain. If he's a driver, your concern is a valid one. Okay, just give me a few moments. I'm going to the next scenario. I'll explain it in the detail in the next scenario. Okay, because next scenario is all about taxi driver, DVLA, and all those things. So we are going to discuss it in more detail. That's why I just raised this point so that you people should not like you people should be fresh and you should think over it that okay, what can we do? So when I will be discussing it with you later, so you will never forget it. Okay, that you will be curious to know that okay, what a doctor can do in this situation. So let's go and check last scenario. So basically we are done with those scenario and this last scenario, TIA and a taxi driver. So you are FY2 in GP, 40 years old man diagnosed with TIA 2 weeks ago. Okay. He was sent to TIA clinic and they confirmed he suffered from TIA. So it means they confirmed and they might have told him to stop driving for 1 month. He was advised not to drive for 3 months. Okay. Here they told him not to drive for 3 months. 2 days ago, you saw him. The doctor saw him driving. So you have arranged an appointment to see him. You have seen him coming today driving as he parked his car. Talk to him, take a focus history, find out why he was driving, and take necessary action. Okay. So here the question is, doctor, if I don't inform the DVLA, will you inform the DVLA yourself? So let's see how to approach. Approach would be paraphrasing. We will be starting this. A better approach would be to do grapes and paraphrase because I understand that you have been asked to come because you have arranged this appointment. That I've been asked to come and talk to you regarding your condition. I understand that you have been diagnosed with TIA recently. Can you tell me more about it? Ask 4 questions. Previous visit question that what symptoms did you have? What investigation did they do? What did they tell you? And what treatment did they give you? And what advice did they give you? Okay. And patient will be telling you everything. And then if they are not telling you about any advice that they stop him from driving, you have to dig out, you have to tell, you have to ask, okay, did they give any advice regarding lifestyle modification as well? You have to dig out the things. So then he will say then if he's not telling again, then you have to ask directly about driving that okay, did they mention anything about driving? What sort of advice did they give you about driving? Okay, he might tell you that doctor, they told me to stop driving for 3 months, and then you would be asking that how have you been in terms of following their advice? Okay, you won't be saying that okay, I watched you, I saw you 2 days ago that you were driving. You won't be saying that. No, you would be asking, you would be digging out this information from the patient that okay, tell me that how compliant are you to their advice regarding stopping driving. Okay, and then if he's not telling, yeah, then you can tell them that okay, few days, because I'm asking, he might say, doctor, I'm not driving, or I'm following their advice like usually patients do. So what you can do is you will be telling them that okay, few days ago we noticed, or I noticed that you were driving today also when you came to the practice. I saw you, you came driving yourself as you park your car. So did you inform the DVLA? What has, he would say no. And then you will be asking that okay, what has prevented you from informing the DVLA? Any particular reason? And can you tell me that in the TIA clinic, did they explain it to you that why you need to inform the DVLA and why you need to stop driving? What sort of problems and challenges you can face if you don't drive? And okay, you need to ask those things that if the patient is not driving, what challenges he might face. But you need to what you need to do is you need to tell the patient that okay, let me explain to you that why you have been asked not to drive. Explain that unfortunately you are more likely to develop another mini stroke or a stroke than someone who has never suffered a stroke before, and the risk is higher when risk is higher within the first few weeks and months. So you need to explain the implications as well, that if you were to develop stroke or a mini stroke while driving, and there is a risk, and you are behind the driving wheel, so there is a risk that you may lose control and get involved in an accident. This may put your life and other people's life at risk, on which are on the road. And unfortunately, if something happens like this, then the police will get involved. They may ban you from driving, and then there may be some severe penalties as well. So your insurance may become void or invalid. You may even find it difficult to get your license back. And then you have to tell them that, as you can see, there are many consequences, many serious consequences of driving while having a TIA recently. So at the moment, you have been asked not to drive only for a short period of time. But if things get worse, if you suffer another TIA or stroke when you are behind the wheel, so the things or the consequences would be worst. And then patient might tell you, the doctor, I don't have any other job, because I have already put a lot of money in buying this taxi, so it's the only thing that it's the sole earning source for me, so how can I stop driving? And then you have to use Eve protocol, because he has um, fired emotions at you, and what you have to do is you have to fire back with the Eve protocol. You have to start with Eve protocol. You will be telling that, I can see that you are worried. I can completely understand why you are worried, and I understand your point of view. There may be some financial implications, okay? And I'm really sorry about your condition. I'm really sorry about your situation. But what I would like to tell you, that you can look into some other options. As you mentioned that you work for a taxi company, so what you can do is you can work in the same company, or you may work in the same company with a different job. For example, you can work as a telephone operator, okay? And some other options may be there, that you can work from home. So, or you can speak to the Citizen Advisory Bureau. Okay, they give free advice. So it might help if you have any insurance and income protection insurance. They might it might help with it as well. Okay, so the advice you are going to give to the patient is that there is Citizen Advisory Bureau. You can talk to them, or you can simply change your job. Do such jobs where there is no demand for informing DVLA. For example, you can work as a telephone operator, or you can change your role in the same company. They can give you another role. You can work as a clerk, okay? You can work as a shift manager as well. So a lot of things. You can give them a lot of options. This is the way, this is the answer to your questions you ask, that okay, how are we going to help him? You can simply, if even you don't know any option, you can just simply refer the patient, tell them that you can talk to the Citizen Advisory Bureau. Okay, and his concern is that, if I don't inform the DVLA, will you inform the DVLA? Okay, so what you need to do is you will be answering that, yes, we might need to inform the DVLA if we see you driving again, but because there is risk of there is risk to your life and also to other people's life. That's why we need to inform DVLA. But before we inform DVLA, we will contact you. Okay, we will contact you again, and we will inform you before we inform the DVLA, and then we will inform the DVLA. So what do you think about what we have discussed so far? And then what you need to do is, lastly, you have to ask them that, okay, you have to advise them that not to drive, and ask them as if somebody has come to take them home, because ask somebody to come and take you home, because you are not allowed to drive. You should not drive back home. Okay, so you have to stop them from driving. So that's all about. So let's start with discharge discussions. So basically, we have got some scenarios where we have to talk to the patients, those who have been admitted in the hospital and now they are ready for discharge, and they have some concerns regarding their medications, or we have to explain medications or procedures or some other techniques, how to take the medications and how to monitor their conditions. Okay. For example, we have the very first scenario in discharge discussion is asthma. So you are FY2 in a medical unit. Patient is a 22 years old boy admitted with exacerbation of asthma 4 days ago. He has been treated successfully and now being discharged today. Nurse has asked you to review him before discharge. He is being discharged on the following medication: prednisolone 30 mg OD for 3 days, salbutamol inhaler as required, beclomethasone inhaler, 2 puffs, PD. Okay, and assess if the patient is fit for discharge. Explain the medications, address his concerns. Okay, sometimes you might be asked to guide the patient regarding a peak flow meter and documenting, taking or positioning, making a normogram where we see that how well the patient's asthma is controlled. So basically how we guide the patient of peak flow meter. You might have seen that it is a device in which the patient blows to see. Peak flow meter is used to assess for pulmonary function test. So to lung functions to check for. It is used for asthma, most of the time for asthma, to see that how well lungs are functioning or how well asthma is controlled. All right. So what we need to do is we need to ask the patient, we need to explain this technique to the patient that, okay, what time you will be using this peak flow meter. So we will be starting, let's start this scenario and we will be discussing it in between. So you have to start with the same approach that, okay, I understand, you can paraphrase, I understand that you have been admitted 4 days ago and you had asthma, and you can simply say that I understand you had admitted few days ago. So could you please tell me what symptoms did you have? What diagnosis did they tell you? What investigations and what treatment? Ask those 4 questions, and then what you need to do is you have to take the history. Take history, okay, and then explain the patient about his condition. That, okay, what is asthma? What is asthma? What do they know about asthma? So you will be explaining asthma to the patient, and then you will be talking about the medications. That, okay, I understand that you have been prescribed certain medications. Do you know how to use them? So let me explain the medications to you. Or do you have any concerns regarding your treatment at hospital, or how are you doing so far? And then you have to start with this asthma, define asthma. That, okay, did anyone explain to you what condition are you having? Explain asthma, that it's a condition of the lungs in which there's narrowing of the airways due to various reasons. This narrowing causes symptoms like wheeze and shortness of breath. And then you have to ask about medications. Go for PMA, Holy Family, in a quick manner and ask about it. Go do your systemic review and then tell them particularly about the medications. Allergies are very important. Allergies, pets, including pets at home, any triggers at home, including carpets, paints, paint activities, okay, paint or sprays, any feathers, and some medications like aspirin, and smoke. Okay, smoke. Do you live around smoky environment, or does anybody smoke at home? any other medical history, any family history, you need to ask detailed things. And then you have to complete your systemic review. And after that, you might be asked to examine the patient, but you have to, because this assessment scenario. So if you are asked to assess the patient and discuss, if it is mentioning that discuss the discharge medication with the patient, then it is simple. You don't have to do examination, anything like that. But it mentions that assess the patient, and then assessment. So you will be examining the patient as well. So there might be a stethoscope in the room. You just need to pretend that you are going to pick up the stethoscope. You need to say that I'm going to examine you. Examiner will give you the finding that everything is normal. Okay. Then peak flow meter or peak flow reading. Peak flow meter might be there sometimes. Okay, it's not always the case. Sometimes there might be there, and then you should tell that, okay, the next thing I want to measure is your peak flow, and then demonstrate to the patient that how do you measure peak flow meter. Then you have to tell the patient that this is a device where you have to blow, take deep breath, and then you have to blow and take average of 3 readings. When you have taken those 3 reading, uh, plot your 3 readings on this. Take best 3 readings and plot the best reading of those 3 on a normogram. Okay, that's a normogram. This is basically used for a representation of peak flowmetry. And then the patient, when comes on the next visit, then we can check that how well his symptoms or condition is controlled. Okay, so for that I will be sharing a link of the video. You can see how peak flowmetry is done practically. Okay, and then once you have done the peak flowmetry, you have to congratulate the patient that, okay, well, congratulations, your reading is good, and you will be able to go home today. And then tell them that you will be given an asthma diary. That you have to do this same thing, peak flowmetry, same thing in the morning and evening, record it in this diary as well, and blow 3 times in the morning and 3 times in the evening, and plot the best reading. And then you have to write this reading on the, you have to plot it on the nomogram and write the best reading on asthma diary. And when you will be coming back, you have to bring this with you, and you have to explain about the medications, that you have been given 2 types of medications. One is a brown inhaler. Brown inhaler is mostly brown, and other is blue inhaler. And blue has got a medication called salbutamol, and it is called a reliever medication. Means whenever you have symptoms, you can take this medication. You have to take 2 puffs, but you do not have to take more than 8 puffs in a day. If your symptoms are not controlled, then you have to come back to us. Okay. And yeah, the brown medication, which is a steroid medication, that is beclomethasone inhaler, 2 puffs BD. So you have to take this medication. It is a preventer medication. It will control your symptoms in the long run. Once your symptoms are well controlled with it, then you won't be needing this blue inhaler frequently. Okay, that's why you have to take it regularly. And then you have to explain the technique, that how do you know how to use the inhaler. Then tell them that, okay, when you are going to use the inhaler, the first thing you need to do is check the expiry date, shake the inhaler, and while you are shaking the inhaler, take deep breaths in and out. Okay, take a deep breath in and then a deep breath out while you're shaking the inhaler. And once you have done it, do it 2 or 3 times, and after that, blow out. The third time, when you have taken a deep breath in and you have exhaled, you have to exhale and hold your breath, and then you have to take the inhaler, put it close to your mouth, and make a tight seal around your mouth. Okay, make a tight seal around your mouth, and then while you are pressing the inhaler, you have to breathe, you have to inhale. Okay, inhale it and then hold it for 15 seconds, and then take another take a break of 15 seconds, and then I just need a break. So the patient might tell you that there is the nurse has already explained to me about the medications, or they might not tell you, then what you need to do is you have to explain about this prednisolone medication, that it is a steroid medication. You have to take 6 tablets because it comes in a 5 milligrams dosage. So you have to take 6 tablets for 3 days, and you have to take them one by one. Okay. And then ask them that if you have any questions so far, you can ask. And this medication should work fine for you. But if you have any problem, any symptoms, then what you need to do is you have to come back to us. Okay. This is all about asthma and discharge discussion.